Hello, and welcome to this video by the theMSAG covering the COVID-19 pandemic to help you prepare for your medical school interviews. As you know, it's important to think about hot topics when preparing. While you're doing so, it's also crucial that you consider different perspectives within each topic. There's a lot of information out there about COVID-19. The information is dense, and it's changing very quickly, which is why you need to keep up with the latest information. In this video, we will be discussing different aspects of the coronavirus. It might be helpful to have a pen and paper handy so you can take some notes as we go along. Let's get started with some definitions of key science concepts to help us understand viruses and pandemics.
To begin understanding the condition COVID-19, you need to think a little bit about what is causing the condition. So let's think about what is a pathogen. You must have heard of pathogens before. You must have heard of viruses, bacteria, fungi, parasites maybe. What makes these pathogens? A pathogen is an organism that can invade a host or a body and can cause disease. But not all microorganisms are pathogens. Actually, it is the contrary. The vast majority of microorganisms around us are totally harmless to humans. Something useful to think of when you try to remember all the various pathogens is the distinction between obligate pathogens and facultative pathogens. Obligate pathogens, as the name implies, are obligated, or they have to, reproduce inside a host. They need a host for their normal life cycle. A very good example is all the viruses. They can only reproduce using the cellular machinery inside a host. Facultative pathogens, on the other hand, are the vast majority of bacteria and fungi that you may see in the environment. They do not need a host to reproduce. They do not need a host for their normal life cycle. But they have the ability sometimes to invade a host, and when they do so, they can cause disease. You do not need to understand the intricacies of the biology of pathogens. But when you want to understand a pandemic, it is helpful to understand the basic differences between viruses and bacteria. So the next step in understanding the COVID-19 pandemic is to understand the word pandemic. Let's look at the words pandemic, epidemic, and endemic together because they're quite similar sounding and they can be quite confusing. I'm going to start with the word endemic. Have you heard that word before? How about if I tell you that malaria is endemic in sub-Saharan Africa? What do you think that could mean? What it means is that malaria has a persistent expected level of presence in sub-Saharan Africa. So endemic refers to the level of persistent presence of a condition or a virus or an organism in a particular area. An epidemic, on the other hand, has nothing to do with the level of presence or persistent presence. An epidemic is an outbreak. It's referring to how many more new cases you see. It's referring to the growth, the rise in numbers. And a pandemic is an epidemic with a P. Think of P as passport. You use a passport to travel in multiple countries and multiple continents. So a pandemic is a growth, it's an outbreak that goes across multiple countries and multiple continents. Let me start with what the R number means, as this is the most essential information you need to start with. It is often referred to as above 1 or below 1. If the R number is above 1, that means that one infected person is going to go ahead and infect more than one new person on average. In other words, it means that the outbreak is still growing. More new people will become infected than the current number of infected people. Now, if you follow the exact same logic, what do you think an R number of less than 1 means? And why do governments talk so much about getting that number below 1? Well, if the R number is below 1, that means that on average, the number of new people getting infected is less than the number of current people who have the infection. That also means that the epidemic or pandemic in the case of COVID-19 is shrinking. Now that we know what the R number is, let's think about its relevance. First, let's consider how is it measured? Do you have any idea how can you measure the reproduction rate of a virus in the whole country? Well, it's a little bit of a trick question. It is not actually measured, but it is calculated. There are very complex models that epidemiologists run to estimate the R number. They take into account lots of factors, for example, how long someone is infectious for, the mortality rate, the number of hospital admissions, the new number of cases. It also takes into account how much people are meeting or the opportunities for contact, as well as the mode of transmission of the condition. The exact way that the R number is estimated is well beyond the scope of this lesson and well beyond the scope of my knowledge as well. But I think what is helpful for you to remember is that it is estimated, and also that it is using past data to make prediction about the current R number or the future R number. And both of these elements can add inaccuracies or uncertainty around the R number.
Thank you for that refresher. Now that we all have a clearer idea about what pathogens, viruses, pandemics, and the R number are, let's wrap our head around the names used to describe the 2020 coronavirus pandemic. I'm sure that you've heard lots of different terms being used during this pandemic, so let's break them down. Coronaviruses are families of viruses that cause illnesses in humans and animals. They cause respiratory or lung infections that can range from mild colds to deadly disease. In fact, coronaviruses cause about 1/4 of all common colds. However, sometimes coronaviruses can be deadly, like the 2003 epidemic of SARS in Asia. The SARS in SARS coronavirus, which is the virus behind the 2003 SARS epidemic, stands for Severe Acute Respiratory Syndrome. As of 2020, SARS coronavirus is considered to be eradicated in humans. A virus similar to the SARS coronavirus was discovered in December 2019, called SARS coronavirus 2. This is the pathogen that caused the COVID-19 pandemic. So why is the current pandemic called COVID-19 instead of SARS-2? Well, viruses and the diseases that they cause often have different names. For example, HIV is the virus that causes the disease AIDS, and SARS coronavirus 2 is the virus that causes the disease called COVID-19. But who gets to decide the name of a virus? Viruses are named by the International Committee on Taxonomy of Viruses, based on their genetic structure. This makes it easier for the scientific community to work on diagnostic tests, vaccines, and medicines. We talked about naming viruses, so who do you think gets to name diseases? Diseases are officially named by the World Health Organization. If the disease caused by SARS coronavirus 2 was called SARS-2 instead of COVID-19, it would create a lot of confusion for people who still remember the 2003 SARS epidemic. The W.H.O have their own guidelines to decide how to best name a condition. We now understand all the terminology used, so we're ready to dive deeper. What is COVID-19? As a prospective medical student, you don't need to know exactly how this disease works, but it is useful to be aware of the basics, such as the symptoms. Why don't you try answering this question now? What is COVID-19? Pause the video and jot down a few notes before watching more. COVID-19 is an infectious respiratory disease. It mainly affects the lungs. The symptoms of COVID-19 are non-specific, which means that it's hard for doctors to know if someone has COVID-19 just based on their symptoms. This is one of the challenges for doctors, as a lot of the symptoms are similar to things like the common cold, and this is why testing is so important. According to the NHS website, the 3 main symptoms are a high temperature, a new continuous cough, or a loss or change in sense of smell or taste. In most other reputable sources, such as the Mayo Clinic, the World Health Organization, or WebMD, the most common symptoms are listed as fever, cough, and tiredness. The loss of taste or smell is also prevalent and is recognized by some to be an early symptom. You may hear about the incubation period of the virus. An incubation period is the amount of time between infection and the appearance of the first symptoms. According to the WHO, with COVID-19, the time from exposure to the moment when symptoms begin is on average 5 to 6 days, but can range anywhere from 1 to 14 days. This is why people who have been exposed to the virus are advised to remain at home and stay away from others for 14 days, even if they have no symptoms. This helps to prevent the spread of the virus, especially where testing is not easily available. The incubation period is important when discussing the handling of the pandemic in the interview. For example, if you are asked this question, do you think making people self-isolate for 14 days is too long? Should the government have asked for 7 days of isolation like some other European countries? What would you say? When thinking about your answer, something good to start with would be to show your understanding about why the UK government chose 14 days initially, and what the incubation period means for the risk of spread of the virus. You should also show understanding that because of the incubation period, people can transmit the virus before they develop symptoms. This is important as longer incubation times can be dangerous. Aside from the incubation period, the way a virus is transmitted from one person to another also has a high impact on its overall rate of spread. COVID-19 is spread through liquid particles produced by an infected person. Small liquid particles are present in an infected person's mouth or nose. Imagine when someone coughs, sneezes, speaks, sings, or even breathes heavily. These liquid particles are dispersed into the air and can easily travel from the infected person to a new person. You may have heard the terms respiratory droplets or aerosols. These words describe the liquid particles I just mentioned, and the categorization is based on the size of the liquid particle. If the particle is larger, it is referred to as a respiratory droplet, and the smaller liquid particles are called aerosols. With that in mind, there are 3 main ways that respiratory viruses can be transmitted. The first is called contact transmission. That's when someone comes into direct contact with an infected person or a contaminated surface. The second way is through droplet transmission of both large and small respiratory droplets that contain the virus. This would occur when near an infected person. And finally, the third method is through airborne transmission of smaller droplets and particles that are suspended in the air over longer distances and times than droplet transmissions. Do you remember early on in the pandemic, when the shops around where you lived were empty of all disinfectant products? Everyone felt the need to wipe all surfaces around them multiple times a day. Desks, tables, and kitchen counters have never been as spotless as during the 2020 pandemic. For a little while, when the pandemic started, everyone worried about surface contact transmission. But recent research has shown that although SARS coronavirus 2 can persist for days on some surfaces, this was unlikely to be a major route of transmission. According to the World Health Organization, most of the transmission occurs through respiratory droplets. These can get into another person's mouth, nose, or eyes when people are close to each other or in direct contact. Remember, it's not only coughing or sneezing. Respiratory droplets travel through just breathing as well. It is understanding this that has led to the widespread worldwide recommendations on social distancing. There is clear disagreement on what the right or safe distance is. While the WHO recommends 1 meter of social distancing, the NHS, CDC, and other official bodies recommend 2 meters. At the beginning of the COVID-19 pandemic, the scientific thought was that airborne transmission was very unlikely. Over the summer and autumn of 2020, the number of people getting infected by being in enclosed spaces with poor ventilation was growing. Eventually, it became apparent that airborne transmission of the virus was real. This led to the development of many more public health policies, such as the closure of public indoor spaces, restaurants, choir practices, fitness classes, nightclubs, offices, or places of worship. Whether the transmission is via respiratory droplets or airborne, it's clear that the transmission is reduced outside. In places that have cold weather coming, socializing outside may be a challenge, and this in turn can increase transmission rates of the virus. Now that we know how COVID-19 is spread, we need to think about how we can prevent its transmission. Pause the video for a minute and jot down a few ideas about how we can prevent transmission. At medical school, you will learn about how to reduce the spread of infections, and a lot of this applies to COVID-19. One of the best things we can do to prevent the spread of COVID-19 is to wash our hands properly. You'll even learn a new way to wash your hands at medical school. It's also important to cover your nose and mouth when sneezing, coughing, and breathing. The World Health Organization recommends that you wear a mask and keep a distance of at least 1 meter when around other people, as well as avoiding crowds or large groups. Earlier, we talked about how important testing is for COVID-19 because the symptoms are non-specific. Early recognition is key to preventing transmission. Let's make sure that you understand the types of tests that exist, what they test, and the difference between each of them. A COVID-19 test can be called many things. Have you heard any of the following? PCR test, nucleic acid amplification test, viral test, molecular test, diagnostic test, serological test, LAMP test. The many names of the COVID-19 test and the misinformation you find online can all contribute to being not too sure about what a COVID-19 test actually is. Make sure you get your health news and scientific information only from reputable sources, particularly when reading about topics that make news headlines. COVID-19 tests can be looked at as two main types, diagnostic or antibody tests. Within the category of diagnostic tests, there are a further two kinds, molecular and antigen.
In your medical school interviews, you could be asked your opinion about the COVID-19 test. Do you think mass testing of the population has been a helpful health policy? You may also be given a role play with a COVID-19 patient asking you about what their options are. Either way, it is important that you have a basic understanding of the various COVID-19 tests. So let's discuss them together. We're going to start with a diagnostic test. Diagnostic means we want to find out if somebody has COVID-19 right now. We're not looking to find out if they've had it before. What we're interested in is, do they have it at the moment that they take the test? So if we want a test that tells us if somebody has COVID-19 at this moment, there are two main things that we could measure. One option is to look for the virus itself, or look for the genetic material of the virus more specifically. The second option is to look for a protein or antigen that is made by the virus. And that creates the two categories of diagnostic tests. If you're looking for the genetic material of the virus from the test, then it is called a molecular test. If you're looking for an antigen or protein made by the virus, then it is called an antigen test. It would be much simpler if everybody called a molecular test a molecular test. But you'll find out in medicine that is rarely the case, and many things will happen to have multiple names. So when it comes to the molecular diagnostic test of COVID-19, there are yet many more names that it can be called. One option is to call it a viral test. Another option is to call it a nucleic acid amplification test. They all refer to exactly the same test. Now, a third alternative is to call it the name of the laboratory method used to detect the genetic material. There's two main laboratory methods that are used to detect the genetic material. One of them is using a method called PCR, and one of them is using a method called LAMP. And so sometimes you may read about a PCR COVID-19 test or a LAMP COVID-19 test. And actually, they're all molecular COVID-19 tests, and they're simply using the name of the laboratory methods used to detect the genetic material to refer to the test. Let me pause a second and recap what we've just gone over. There are diagnostic tests in COVID-19 that allows you to know if the person being tested has the disease at this moment in time. If you're looking for the genetic material, then the test is called a molecular test. That molecular test can have many names. It can be called a molecular test, it can be called a viral test, it can be called a nucleic acid amplification test, or it can be called the laboratory method used to detect the genetic material. two main laboratory methods are used, PCR and LAMP. So if you see PCR tests for COVID-19 or LAMP tests for COVID-19, they're all referring to the molecular diagnostic test. Now we're almost done with the new terminology, but there is one more term that is commonly used to refer to this molecular diagnostic test, and that is RT-PCR. Now we've just mentioned PCR as a lab method, so what is RT? What I didn't tell you is that PCR can only detect DNA. The coronavirus is an RNA virus, so it requires an extra step to be able to be diagnosed with PCR. We first need to make the RNA into DNA, and then the PCR test can measure whether it's present or not. The steps that makes RNA into DNA uses an enzyme called reverse transcriptase, or RT. PCR and RT-PCR are not the same thing. PCR works on DNA. RT-PCR is PCR, but with an extra step first that makes the RNA into DNA. However, when you see PCR test or RT-PCR test in context of the COVID-19 diagnostic test, they are referring to the same test. I do not imagine that your interviewer during your medical school interview will ask you about the RT-PCR test. But knowing this can help you read the literature about COVID-19 better, knowing what they're referring to. And also, since you're applying to medical school, I assume that you would be interested. But let's go back to the information about the test that will be more helpful for your interview. The second type of diagnostic test for COVID-19 is the antigen test. Remember, we mentioned this is the one where we're not detecting the genetic material, but instead we're detecting an antigen made by the virus. If you think about it from a patient perspective, whether they're getting a molecular test or an antigen test doesn't make that much difference. Their experience is very similar. They have to go and get a swab and then wait for the result. And the result will give them information about whether they have COVID-19 at this moment or not. However, the final type of test is a very different experience for the patient, the one called immunity test. This one also has multiple names, as you could have guessed. So what are those names? It is known as the immunity test. It is known as the antibody test. It is known as a serological test or serology test. It is also known as the blood test. And that is because for the immunity test, the sample that you need is a blood sample, not a swab. What the immunity test is testing is very different than what the diagnostic tests were testing. Now we're looking to find out if somebody has had COVID-19 before. Has somebody mounted an immune response to COVID-19? It doesn't give you information about the current status of COVID-19 infection of the individual who takes the test. No one expects you to know everything about the COVID-19 test, but it is very good if you get asked a question about the test, that you're able to show that you understand that not all tests are the same, that you understand the difference between an immunity test and a diagnostic test, the different types of samples that one can use, and what information we're trying to find out with the various tests.
Well done. You've survived the scientific definitions, the clinical presentation, the transmission methods, and the testing. As an aspiring doctor, I'm sure you have an interest in how you can treat patients to make them better. Have you heard of any treatments for COVID-19? If you have, this is a great time to pause the video and write them down. At the time of preparing this lesson, there is currently no cure for COVID-19. You cannot use antibiotics, as this is a viral infection and not a bacterial infection. Antibiotics cannot be used for viruses. Even though there is no cure, we do have things that we can do as a doctor to help patients. A lot of the treatment is supportive. This means that we aim to help provide symptom relief. This might include things like oxygen therapy, fluids, and ventilation. There's good evidence that steroid treatment helps to reduce mortality for COVID-19. The steroid that has been found to be most effective is called dexamethasone. If patients become unwell with COVID-19, then they often require to be moved to an intensive care unit. In intensive care, they get more support, which often includes ventilation. A ventilator is a machine that helps you breathe by mechanically pumping oxygen into your body. The air flows through a tube down into your windpipe. Let's think about how COVID-19 affects people around us. It's more likely that an interview question on COVID-19 asks for your opinion on its impact, rather than pure scientific facts. Let's think about what happens to people who get COVID-19. Most of us know someone who's been affected by COVID-19, and it does affect different people in different ways. Around 80% of people who get COVID-19 recover from it without needing any hospital treatment. Some people are asymptomatic, which means that they could have COVID-19 and never know, because they don't show any symptoms at all. Around 15% of people become seriously ill and require supportive treatment such as oxygen therapy. Around 5% of people become critically unwell and need intense care. Some of the complications of COVID-19 include respiratory or lung failure, blood clots, heart attacks, and tragically, death in the worst cases. Who do you think is more at risk of more severe illness from COVID-19? COVID-19 can be serious in anyone, but there are certain groups who are more at risk of severe illness. As you may have heard in the news, COVID-19 is often much more serious in people over 60 years old. Some other groups are at risk of severe illness as well. This includes people with underlying medical problems, such as high blood pressure, heart or lung disease, diabetes, obesity, and cancer. It also includes individuals who are immunosuppressed, either because of a medical condition or because they may be taking immunosuppressant drugs for a medical condition, after a transplant, for instance. When we think about COVID-19, we often think about the short-term consequences. Most people recover quickly from COVID-19, within a couple of weeks. However, the effects of COVID-19 can last for weeks or even months in some people. This has been called long COVID. The symptoms of long COVID include things such as tiredness, breathlessness, depression, chest pain, and brain fog. We know it can be overwhelming hearing and thinking about the numbers around COVID-19 as they're constantly in the news. You don't need to know exact figures, but it's important to have an idea about the key statistics. The information I'm about to give is up to date as of the 26th of November 2020 and is specific to the UK. There have tragically been around 58,000 deaths from COVID-19. In the early weeks of the pandemic, deaths doubled every 4 days, peaking at around 1,000 deaths per day in April. The deaths have mainly been seen in people over 65 years old. The north of England was particularly badly hit by COVID-19 deaths. In the UK, a greater proportion of deaths due to COVID-19 has occurred in those of Black, Asian, and other ethnic minority backgrounds. By the end of the first week of December 2020, there have been about 1.7 million positive cases of COVID-19 in the UK. Now, let's discuss the main exit strategy from this pandemic: vaccines. The progress on vaccines is changing all the time, so make sure you're up to date with the latest information. In the first week of December 2020, patients began to receive the first COVID-19 vaccines in the UK. Before we talk you through the recent COVID-19 vaccine announcements, let's make sure you remember what vaccines are and what herd immunity is.
Vaccines are a whole topic in themselves, and we will have a full lessons dedicated to them. But for now, let's just make sure that you remember the basics about vaccines. What are vaccines? And most importantly, what are they made of? Why are some people scared of vaccines and scared of their secondary effects? Well, vaccines are made of the viruses or components of the viruses that you are trying to protect yourself from. Take a measles vaccine, for example. A measles vaccine has the measles virus in it. Now, those viruses have been either killed before they've put into the vaccine, or they've been seriously weakened so that the vaccine does not make you sick. The idea is that if you take a vaccine that has a killed virus in it, a weakened virus in it, or a protein or an element of the virus in it that your body can react to, then your body will mount an immune response to that virus. It will create antibodies, so that the next time when you actually catch the virus unwantedly, your body is already ready to respond to it and fight it better. The final concept that I'd like to clarify, linked to vaccination, is the concept of herd immunity. Herd immunity is a concept by which we say that a population can be protected from a disease or a condition if enough members of that population are vaccinated or have antibodies against that disease. The number of people in a population that need to have antibodies in order to provide herd immunity differs from one condition to another. For example, for a population to be protected against measles, you need 95% of the population to have antibodies. But when you look at something like polio, then if 80% of the population have antibodies, the population is considered to be protected against polio and have herd immunity.
That was a great reminder. As of December 2020, there were 57 vaccines for COVID-19 in clinical trials. The three most promising at that time were the vaccine from Pfizer-BioNTech, the vaccine from Moderna, and the vaccine from Oxford-AstraZeneca. The reason why these three vaccines were the most promising is that they all showed positive results from interim analysis of their Phase 3 vaccine trials. At the beginning of December 2020, the UK became the first Western country in the world to approve a COVID-19 vaccine, the vaccine made by Pfizer. It has been shown to be 95% effective in trials. In total, the UK government has secured early access to around 350 million vaccine doses, with 6 separate vaccine developers. We'd like to end this lesson by going a little beyond the UK and looking at what's happening around the world as well. By December 2020, globally, there have been around 65 million cases of COVID-19 detected and around 1.5 million deaths. Arguably the most important global organization in this pandemic is the World Health Organization, W.H.O. The W.H.O. is a specialized branch of the United Nations, which is responsible for global public health. The WHO has lots of functions, but during this pandemic, its most important functions are helping countries prepare and respond to COVID-19. They did this by providing accurate information and coordinating the Solidarity Trial to help find medicines for COVID-19. How each country in the globe responded to the COVID-19 pandemic is well beyond the scope of this lesson. However, we do want to mention South Korea as an example of a country that handled the pandemic well in the eyes of most. South Korea stands out as they managed to get control of the pandemic without closing businesses or telling people to stay at home. South Korea quickly started mass testing. Early in the pandemic, they were testing more people as a percentage of their population than any other country. If a patient tested positive, then they would help them quarantine and trace any contacts they interacted with who may also have the virus. South Korea's tracing system is extremely detailed, with intelligence officers using CCTV footage and even credit card statements to track where positive patients had been. Most of the literature you read about South Korea's handling of the pandemic portrays it as an example for other countries, but there are also some that raise concerns about privacy of individuals being breached in the name of the greater good. Should everyone's whereabouts be made public to help prevent the spread of COVID-19? Should every individual's information be accessible by monitoring services? Are there long-term risks to this? Or just the positive impact of a reduced spread? We're going to leave you all these interesting questions to think about. It's food for thought in anticipation of our next lesson, where we look at the impact of COVID-19 on various groups: patients, the NHS, the government, doctors, and healthcare professionals. We will aim to understand conflicting perspectives on this topic. Thank you for listening, and best of luck with your medical school interviews.